Hi everyone, and welcome to another episode of 101 Thought. I'm Jessie. Today we'll be discussing disparities in cancer prevention and care. As many of you already know, cancer affects the lives of millions of people globally and is the second leading cause of death in the United States. Luckily, we have technology that allows us to conduct cancer screenings which can detect precancerous cells, which is ideal for early diagnosis and treatment. However, not everyone has equal access to these methods, and even after being diagnosed, many patients experience hardships physically, emotionally, financially, and so much more, which can all impact the way that they make decisions and the way that they receive care. And to help speak more on this subject, I'm joined by Dr. Sarah Hawley. She's a professor of internal medicine, health management, policy and health behavior, and health education at the University of Michigan. And she's been working there for over 15 years and has done extensive research regarding the improvement of cancer care and the decision-making process for patients from the beginning to the end of their treatment. Welcome, Dr. Hawley. Thank you for joining us.
Thank you for having me.
So to start off, I was hoping you could tell us a bit about how you got into research and what piqued your interest in specifically cancer research.
Sure. So I'm a native Michigander and grew up in Michigan in Ann Arbor and went to University of Michigan undergrad, where I was interested in health and medicine and really wanted to be at that time pre-med, and kind of set out on that path and was rather quickly deterred by organic chemistry. I'm not going to lie. And at the same time, I was taking several political science classes, which were also interesting to me, and happened to come across the School of Public Health, which is located up on the Hill. And I had not really been familiar with that as a graduate program. So when I kind of researched more into their offerings, I learned that they had a health policy track. And that seemed like a great way for me to combine my interest in health and medicine and policy from a different perspective than actually being a clinical physician. So I kind of switched gears and ended up going on to grad school, first a master's program and then on to a PhD program in kind of health policy and health services research. And it was during my PhD program that I became very interested in the issue of kind of access to care and from a policy perspective broadly and cancer care specifically. And I was doing my work at the University of North Carolina in Chapel Hill and became very well aware of a lot of disparities in access to cancer screening that existed both between rural and more urban areas of North Carolina, as well as between African American community members and Caucasian community members in North Carolina. And so I joined a research project that was looking at how to meet that gap and how to bring mammography screening to rural residents of North Carolina. And the more that I became involved in that project, the more interested I got in not just policies around helping patients get to the care, but what role did physicians actually play in communicating with patients about the care options and the screening options that they had, and was there disparities there? Could we improve the recommendation process? Because patients tend to do what their doctors tell them to do, and yet there's lots of different ways that recommendation can be delivered. And I kind of embarked from there in a career of kind of looking at the role of physicians, patient-physician interaction, communication, decision-making, and that has kind of brought me to where I am now, which is kind of focused very broadly on cancer care delivery, looking both at studying the problem through observational studies, surveys, secondary data analysis to kind of understand what gaps there are, what disparities do exist, how can we learn from asking people and looking at data sets about what issues exist, and then at the same time, interventional work to try to meet some of those gaps. And I've really shifted a little bit more toward the interventional side in my later career, because I think we need interventions to get out to people to kind of meet the needs and fix the gaps. So that's kind of a nutshell version of my trajectory. I got back to Michigan in 2004, and as you said, I've been here since.
Yeah, that's awesome. I know a lot of people see pre-med and medical school as the only way to get involved in the healthcare field, so it's cool that you found another option, and there are so many other options and great ways to get into it.
And I'll just add to that, it's true. And I think I learned that kind of by accident, but I'm now a professor in the Department of Medicine. I thought that I would be in a school of public health doing primarily teaching, which I do really enjoy doing, but instead I sort of had to make a choice between where to primarily house my appointment. And I like to be in a clinical department where I'm surrounded by the clinicians who do the actual clinical work that I'm interested in. So I have found that to be a really nice way of merging those two interests as well, and to kind of keep me fresh with regard to the clinical issues. I can go, in normal times to the office next to me and say, is this a problem, that you would find in your practice? And if they agree, then I can go ahead and pursue it a little bit more from a research perspective.
Yeah, it's awesome to have the both sides of the situation. What current problems do you see with cancer care today, and what is your research doing to alleviate these problems?
So cancer care has come a long way since I first became interested in, breast cancer screening access way back in my PhD program. During that time, which was the 90s, which is kind of difficult for me to admit, but it was a time where the problem was really getting people screened. We had screening tests that worked. We had mammography, we had colon cancer screening, we had PSA screening for prostate cancer was being done. And we really had gaps and problems and disparities in getting those tests out to everybody. So that was kind of the focus of the research then. As time has gone on, we continue to have that problem in some aspects and in some areas of our country and certainly globally. But we also have another problem, which is in some cases, people are getting too much of things. They're getting too much testing, too much screening. People who are over age 85 getting colonoscopies doesn't tend to make a lot of sense these days. And we've learned a lot more about kind of a risk-informed approach to delivering care to ensure that the screening test is going to do what we want it to do, which is help identify a potential early problem that can be further explored and potentially addressed to catch cancer early and treat it before people get to a very late stage where it becomes difficult to have a curative option. So I study now both sides of the spectrum, and that's not only true in screening, it's true in treatment as well in cancer. We have many evidence-based interventions and treatments that aren't getting to people the way that they should. But we also have examples of treatments and interventions that are being used in a way that we could argue is not really helping people. There's probably more harm to that than benefit. There's not a survival benefit. A really good example of that is bilateral mastectomy, which is a treatment that I've been studying from a decision-making perspective. Why do patients make that choice? That is the removal of a healthy breast in a breast cancer patient who has cancer diagnosed in one breast, sort of removal of both breasts, which also typically comes along with breast reconstruction. Most patients want to kind of, once they have the bilateral mastectomy, they want to have a breast shape or a breast, looking shape afterwards. So they have breast reconstruction. So instead of one potentially small surgery, which would be a lumpectomy or a breast conservation surgery, they're actually having 4 surgeries, which is a huge difference in terms of the amount of surgery on a particular person's body. And so there's complications, there's recovery. And so we've been really interested in what has driven that choice and why we've seen the rise in that, and trying to understand, a lot of the motivations on the patient side that go along with a choice like that, as well as the provider side, as well as external influences. So I'm happy to speak more about that work, but there's other examples of kind of what we call overuse or overtreatment in overdiagnosis in cancer. And we also have the ongoing problem of making sure that everybody gets the treatments that we know do work. So we still have the problem of undertreatment. And so I do work in both areas with a specific interest, as I mentioned, in really the delivery of patient-centeredness. So how do we make sure that regardless of what patients get or when they're faced with choices, that they really are armed with good information about how to navigate their cancer and its treatment. They feel involved in the decision. They feel like they have full information. They feel like their doctor listened to them, talked to them, understood their preferences. Not everybody prefers the same thing, particularly when there are choices. In cancer care, there are often a lot of choices. So the interventions that I have primarily done have been around decision making and decision tools and decision aids to help patients and their physicians make good, shared, patient-centered decisions.
Awesome. Would you say that people in low-income communities are usually the ones who are underserved with cancer care and don't have the same amount of choices?
So I think that we still do have in this country differential access to care. And yes, we see kind of traditional underserved populations, low income, rural populations, often just because of distance issues, and often rural communities don't have huge, delivery centers located in them. And so getting to the care can be challenging. The same is true for sort of an inner city low income area, often may not have a delivery system available to a lot of people. Racial ethnic minorities remain, there remain unfortunately differences in access to care that really do need to be fixed. So, and there's a lot of reasons for that. I mentioned, there's the income, there's the location and distance issue. There's an income issue that has to do with kind of co-payments around insurance that can sometimes be harder for people. There's a lack of insurance, which unfortunately we still have in this country. Millions of people don't have health insurance, even though we've been really working to try to improve that through things like the Affordable Care Act. But unlike a lot of our European counterparts, we don't have a system of care where everybody can get care without having insurance. But we don't have socialized insurance. And so what happens is people tend to not purchase insurance or delay care because they don't want that co-payment around the insurance, or they don't want to have to pay out of pocket. They end up in the emergency room and often delay things that seem more optional, like cancer screening. It's really difficult to do a regular test when you don't see an immediate benefit of it. It's helping to prevent something, and that's not visible to us. So when you have to make a choice around something, that's often something that can be pushed off.
Yeah. What do you believe are easy ways for people to spread awareness about preventative cancer health measures and other preventative care?
I think we need to continue to, make public education accessible through, we have, luckily these days, we have a lot of avenues for that. We have social media, we have digital methods. We still have, posters and, your traditional older print methods, things that go up into health systems, into doctors' offices, into community centers where people go. I'm a member of the Rogel Cancer Center at the University of Michigan, and I also co-direct our center called the Center for Health Communications Research, which is a shared resource of our cancer center. And we've been trying to push out a text-based program, which is around kind of cancer prevention activities. And we did it text-based because we wanted to develop an intervention that would have broad access, that would be easy to use. It doesn't require a smartphone. And so it's called Tips for Health. And that's something that we've been making available in our state that helps people to do things like, if they want to quit smoking, it's a smoking cessation module. It has an eating healthy module. It has a exercise module. And then we just developed a colon cancer screening module. So we're hoping to pair that module with a health system approach to actually get people a screening test if they're interested, or a referral for a screening test. So those kinds of things, I think, are avenues that we can use to just try to increase the access to information.
Yeah, definitely. Is that something that's already been released and people are using?
Yes.
And how would someone find something like that?
tipsforhealth.org, or you can text TIPS to 734-212-5655, 5123, and you'll get a question around which program you want to join. And you can sign up for either of those 3 programs that I mentioned. The colorectal cancer screening one we're waiting to offer because you can sign up for it, but we really would rather have it partnering with a healthcare provider.
Awesome. Thank you for that resource. I know you mentioned earlier that you did a lot of work in cancer care decision, and especially with the bilateral mastectomy. And I was curious if you saw family support in their decisions as a big factor when they were making the decision to get that specific type of mastectomy.
Yeah, family support is really important. In fact, I have a line of work that I'm trying to grow in that particular area. So a lot of times we focus decision-making tools on just a patient. That's kind of how the whole original idea of a decision aid was born. You develop something that a patient can use, whether that's a pamphlet or a website or an app these days. And we know, but what we know is that no patient makes a decision truly alone, particularly when they have a cancer diagnosis. They don't go home and sit in their bedroom and kind of decide what to do. They immediately reach out to their family and their friends, and even sometimes more broadly, even on social media or other ways to kind of get people's help, support, and advice for what to do. So yes, the role of families is very important. We've done some survey research that's shown when a breast cancer patient has what we call an engaged decision supporter, so that's someone that understands what their cancer is. They kind of understand the risks and benefits of the different treatments that the patient is undertaking. They're aware of the patient's preferences, and they've been involved in the decision-making process with her, that patient has higher decision satisfaction. So we know it's a good thing. We need to figure out ways to develop tools that can kind of interactively include the patient and the other people that she wants to involve in that decision.
Mm-hmm. And I know we spoke a little bit about government policies involving healthcare, and you have done a lot of research in health policy. And what is your view on the policies that are already in place, and what would you like to see be put in place in the future?
So yeah, interestingly, my degree is in health policy and administration. But during my doctoral program, I sort of veered that more into true kind of what we call health services research. So more statistically based, kind of more research methods based, and less kind of on the policy advocation side of things, and kind of studying the impact of policies as much as I thought I would be doing originally when I went down that path. But we're very fortunate at the University of Michigan to have the Institute for Healthcare Policy and Innovation, or IHPI, which is a great resource to, go online, and kind of lots of postings on their website and information about what various members have done and are doing with regard to specific policies. So that's like things like Medicaid and the Medicaid expansion program and things like that. So for folks who are interested, I would highly recommend checking out IHPI. But, me personally, I feel, we've seen a lot of benefit for things like Medicaid expansion. We want people to have access to health insurance. By we, I mean people like myself. Most clinicians, want people to be able to get healthcare with as low co-pays as they can. And our system is structured so that most health insurances, we're very fortunate when we have employers offering us good healthcare. We have a choice. For instance, at the University of Michigan, we have a nice menu of choices. You can choose the program that you like the best. You can choose if you want more co-pays or more choices, and all of that is really nice. We're very fortunate to have that, but it kind of assumes a good employer, a big employer who
Right.
can do that, and kind of a level of income that you want to go kind of make those choices. Many people don't have that ability, so they either have a small employer who can offer only one option, or, they are working with the Affordable Care Act and need to kind of buy off an exchange type program, or people like I talked about earlier don't have any options and choose not to buy anything. And so we have a lot of good pieces. My personal feeling is that it's very fragmented. So for instance, when you turn 65, many individuals continue to work. So they have their employer-based insurance, and they also have, at least for now, Medicare. So they almost have more insurance than they need. And we also have people in this country who don't have insurance at all. So I feel like we could do a better job of leveling that. But that's going to take significant change that I don't really see happening very soon. And that's just, again, my personal opinion about
Thank you for
insurance.
sharing that. Just to wrap up, I know that you've had such a great experience in the healthcare industry, and if you could leave our listeners with any advice on how to get involved or just any tips for getting into the healthcare space.
Well, I think as we kind of started out talking about, healthcare is very broad. There are so many different avenues and there are so many needs. There's needs on the policy side as well, which wouldn't necessarily be a healthcare major even. It might be a policy major or a law major that then, later in life was used to kind of focus on health policies, or at a government level to focus on, affecting change in terms of our health coverage. There's lots of different ways to be part of healthcare, and I think it's just a huge need in our country. It's a basic need, and I think we can do a better job than we are currently doing of making sure everybody has access to care, the care that they need, and we don't undertreat people. But also we need help on the other side to make sure that we aren't rationing care, but that we're not overusing care that we don't need. It's very costly and it puts a lot of people in harm's way. And that educational piece is very difficult to get out there as well, because when you talk about sort of de-implementing something, people get very nervous about that. So I just encourage people to think broadly. With regard to cancer care, I think there continues to be a need for research across the continuum of cancer care, from prevention through even end-of-life care. An area of growth that has just exploded is genetics. We're learning that cancer is really a genetic condition. It's much more genetically based than we realized many, many years ago. And so as we learn more about that, there's such a huge need for genetic testing, genetic counseling to help patients understand this, to help their families understand what this means, how to help people prevent certain types of cancer if genetic mutations are in place, which can have some very difficult decision-making pieces to it. So there's a whole lot of needs in that space as well. So we can definitely use young folks with interest in, that area specifically, but also more broadly.
Well, thank you so much for talking to me today.
Thank you.
Thanks for tuning in to this week's episode of 125 Thoughts. We had a great time talking with Dr. Sarah Hawley about her research on cancer care and prevention. Don't forget to follow us at 125 Thoughts on Instagram and Twitter. Again, it's at 125 Thoughts on both Instagram and Twitter. Thanks so much for tuning in. See you next week.